include the following. The patient comes to you, so what do you have to do with him? First thing first, you have to diagnose him. ECG. What's next? You have to do rate and rhythm control. Well, you take a look at him. Is he stable or not stable? Guys, you must know this stuff. So let me make you a quickie graph about this. So someone has an AFib. First question you ask yourself, is he stable or not? Stable? If the answer is yes, awesome, you can use medication. If the answer is no, he's not stable, you have to electrocute him. What is the definition of a stable? Well, the definition of a stable is someone with a blood pressure more than 90/60. Anybody with a blood pressure less than 90/60, we say he's unstable. More than that, he's stable. Okay, what about if they are really horrible people and they hate you and they put it exactly 90/50? If they put it exactly 90/50, it means two things. They really hate you and you have to do the next step. You have to check the heart rate. If it's 90/60 and the heart rate is equal to more than 100, he's unstable. If it is less than 100 but more than 60 beat per minute, it means that he's stable. If it's less than 60 or more than 100, he's unstable. Okay, let's go back to this. If he is unstable, what should you do? You do something called cardioversion. So you basically electrocute him. That if he was unstable. But if he was stable, you do rate and rhythm control. 90/60. Yeah. So you do cardioversion, but guys, it's pretty easy to do this one now. Why? Because the machine checks. The machine checks, and it's not like a defibrillator, it's different. The machine checks the P wave, QRS complex, and the T wave, and the machine should make sure she never hit the T wave. Why? If it hits the T wave, you get a syndrome called shock on T wave syndrome, and the patient dies. That's it. There is no way to save him if he has that. So the machine actually now, our machines check, and they only give the shock on the before the T wave, okay? Like at the QRS complex or any time before, but never they give it at the T wave. But for you to know, what you need to know is that if the patient is stable, in case of AFib, you have we call this synchronized shock. So if he's stable, you have to give him calcium channel blocker or beta blocker. Beta blocker are the preferable option, but if someone has asthma, for example, you will never give him beta blocker because they lead to bronchospasm. So you must give calcium channel blocker instead. Okay, we did this. His heart rate now is back to norm. What should I do next? Well, the thing that you must do next, it goes something like this. You need to take a look at his, you did the rhythm control, you did the rate control, all good. The patient is stable now. So you want to make sure that he does not have a thrombus inside of his heart. Exactly. So before you give the anticoagulant, you need to check one thing. You need to check if it is located there or not. To check for it, you do a test. It's called echocardiography. So you do the time of the symptoms is cool, but that's a step 2 question. But okay, if you want me to add that, I will add it really quick. The time of the symptoms, is it more than 3 days or less than 3 days? If it is more than 3 days, that's it. You give him the anticoagulant. Done. But if it's less than 3 days, you must look at the heart. How do you look at the heart? You do an echo. Well, do you do a transthoracic or a transesophageal echo? Well, it's possible to do both, but which one is more sensitive and more specific? As you wrote, guys, it's a transesophageal echocardiography. How come? Why it's the most specific? Which chamber of the heart are we checking? The left atrium, and it is located anteriorly or posteriorly? Posteriorly. Yes, it's posteriorly. It's the closest to the esophagus, exactly. So if you imagine that the esophagus is here, the left atrium will be basically located here. So when you insert the ultrasound machine, it will be checking this view. Yes, it will be looking here. So you will be able to see if there is a thrombus here. If you see the thrombus, you are like, you cutie, let me give you some anticoagulant. So your next step, if you find it, is to give anticoagulant. In the future, I will be telling you when we do hematology that the anticoagulant of choice is heparin. We give the heparin, and after we give the heparin, we need to give also warfarin. But there is a test we must do before we give these and keep checking it. Exactly, guys. The INR. So you do the INR. In addition, you need to do the BT and the BTT to check the coagulation activity inside of the body. These we'll speak about in depth when we do hematology. But for now, I want you to know that you must do rate and rhythm control, you must do an echo, and you must do the anticoagulation therapy. Be careful. If he's stable, don't do this. Go for cardioversion. Which form of cardioversion? Synchronized. You do synchronized cardioversion. In case of mitral stenosis, only warfarin. Well, the thing is, it's possible, but you need to keep in mind that if you give warfarin alone initially, it can have a risk of thrombosis initially itself. You're like, no, wait a second, warfarin is an anticoagulant. Yes, but initially there is a transient phase that warfarin can lead to hypercoagulability and then hypocoagulability. And thus, you give both of them, then you stop the heparin and keep the patient on the warfarin. Okay? Why? It's like a bridge. You are bridging the hypercoagulability state. It's possible to give aspirin, and we do give aspirin to prevent further coagulation, but it does not clear the thrombus you already have. To try to clear the thrombus that you already have, you need something more potent than aspirin. Aspirin won't do it. So you will need warfarin, and you will need, exactly, it's an antiplatelet, it will not do it. It will prevent further aggregation, but you already have a thrombus and you must deal with that. Okay, so now you read first aid and you totally understand every single point. If you say that the patient, like here, treatment, anticoagulation, rate and rhythm control, or cardioversion, and we said in each one, these steps faster, please. I mean, after we decide if the patient is stable or not. Okay, so if the patient is stable or not. If he's unstable, we do cardioversion. We just put this machine on him, it shocks him, done. If he is stable means his blood pressure is more than 90/60, we have to do rate and rhythm control. The rate and rhythm control is done by calcium channel blocker and beta blocker. And when you do this, his heart rate, what is the normal heart rate of someone with an AFib? How much do you think, guys? How much does an atrial fibrillation patient heart rate is? It's variable, but basically, to make it simple, it's ridiculously high. Okay? Some sources say 300 and up, some sources say 150 and up. But personally, I think it's like more than 200 or 300, and the flutter comes in between like 100 and 200. But in general, it's high. That's what you must know. It's like ridiculously high. And if that is the case, when you do the rhythm and the rate control, it goes down. So when it goes, wow, you man, just awesome. Yeah, see this picture, guys? It's exactly what I was speaking about. It's like you do the rate control, then you check how long it has been. If it's been like more than 3 days, you have to give the anticoagulation. And if it's less than 3 days, you have to give the transesophageal echo. And then you check for a thrombus. No thrombus? You can do chemical or electrical cardioversion. Cardioversion has two types, chemical and electrical. Does anybody here know how can we do a chemical cardioversion? I mean, electrical, it makes sense. We just put this machine to shock him. But how can you do a chemical cardioversion? Chemical, not the ablation of the fossa. That's totally mechanical. It's a drug. Butylide, we can do that, but there is one that is mostly used much more than butylide in the clinic because it's cheaper. Exactly, amiodarone. So we use amiodarone for chemical cardioversion, which basically put back the heart on. So you did the rate control, it put the heart back in the rhythm. So that's your function now. You need to put the heart back in the rhythm. You did the rate here, now it's time for the rhythm. Yeah? So we fix the rhythm. How? With cardioversion, either chemical or electrical. Good, guys. So now let's speak about atrial flutter. It's a rapid cessation of identical back-to-back atrial depolarization wave. Guys, do you remember the B wave? If you take a look here, how do you check for B wave? QRS, behind it, here's a B wave. Wait a second, B wave, another B wave, another B wave, another, too many B waves. What does that mean? Well, if you have too many B waves back to back, that means that your atria is depolarizing so many times. How come this is happening? Well, there is some ectopic foci located near your SA node, located in your right atrium, that leads to recurrent impulses. So that leads to the creation of this sawtooth pattern. This is basically a lot of B waves next to each other. And it happens due to an ectopic foci that is located near the, tell me guys, where is the ectopic foci for the tricuspid? Shit, I said it. Okay. It's near the IVC and the tricuspid. Yeah, it's tricuspid isthmus, exactly. Okay, so please note, in atrial fibrillation, RR interval is different. In case of atrial flutter, it's the same. So, they write, the identical appearance accounts for the sawtooth appearance of the flutter waves. A treatment exactly like you did in atrial fibrillation. That's why I spent time on it, because it's two-in-one type of thing. But here there is catheter ablation, and you can do ablation here. But I want a really smart person to tell me in which condition of these two conditions you must penetrate a structure that originates from the septum primum. Excellent, atrial fibrillation. You must penetrate the what? The foramen ovale, the fossa ovalis. And thus, fossa ovalis, it's created by the binding of septum primum and septum secundum after birth due to the increased left-sided heart pressure compared to the right-sided heart pressure. Excellent job, guys. They do ask this actually, so keep it in mind. By the way, guys, I know a lot of you started to do U-word. If you are doing horribly on U-word, it's okay. That's your baseline. I got this question today. See? It's important. Okay, so the next one. Here we have ventricular fibrillation. It's completely erratic. What does it mean? If you look at the QRS, yes, it's wide, but here's the thing. It's just random stuff. It's completely erratic rhythm with no identifiable waves. So it's fatal arrhythmia without immediate CPR and defibrillation. Notice here, guys. What is the first thing you do for someone with a VFib? What is the first thing? You saw someone, you check the heart rhythm, he has a VFib. What you should do? Now, the first thing you must do. Come on. We look at him and we start chest compression. Guys, please do not be tricked. Do not choose a defibrillation. Do not choose check anything. Do not check anything. Do not do anything. You see a ventricular fibrillation. Don't do anything. Start chest compression. Okay? You do the chest compression. You have initiated. Excellent. You can do the other stuff later. You can defibrillate him later. But the main thing now, in ventricular fibrillation, the ventricles is not contracting. So there is no blood going to his brain. So you have only 5 minutes before this patient dies. There is no time to bring that defibrillator machine, you know? So the first thing you do, you start chest compression to push that blood a little bit to his brain. Then you start thinking about what should I do next, you know? Keep in mind that it's defibrillation, not cardioversion. Cardioversion is basically someone have bad rhythm and you want to correct it. Defibrillation is completely erratic, and it's basically no rhythm. There is no normal rhythm at all. Here it's just the rhythm is dispersed in case of AFib and atrial flutter, but in case of ventricular fibrillation, basically normal rhythm is absent. Okay, so the AV block now has the 3 types, and the affection now goes like this. So we spoke about diseases yesterday that they affect the QT interval. Today we spoke about some diseases that they affect the P wave. We now have to speak about diseases affecting the PR interval. Guys, what is the difference between an interval and a segment? Someone said interval no waves, somebody said segment no waves. Okay, so the interval has waves, the segment does not have waves, okay? Good. So remember, the word segment does not have V in it, so no waves. So AV block. So we have in all of the AV blocks, the BR interval will be what? Wide or narrow? Which disease we spoke about had a narrow PR interval? We spoke about one disease that had a pretty narrow. Oh yeah, it's Wolff-Parkinson-White syndrome because of the delta wave and the pre-excitation of the ventricle. Excellent, because of the bundle of Kind. Okay, good. So here we see that we have 1st degree, 2nd degree, and 3rd degree. So the 1st degree AV block, the PR interval is prolonged. Prolonged is defined as 200 milliseconds. Guys, 200 milliseconds is how many big boxes? Wolff-Parkinson-White syndrome, for the person who asked, Wolff-Parkinson-White syndrome, you can see here the PR interval and it's quite small. While in case of AV block, the PR interval will be quite wide. If yes, exactly, as you said, guys, it's one big box, and that makes 5 small boxes. One small box is how many milliseconds? Yep, excellent, good. So the PR interval is prolonged, and it's benign and asymptomatic. It's just the PR interval that is long. It does not have symptom. Treatment is not required. It's all perfecto. Good. So you don't have to do anything. The next thing is the next thing is to do is a 2nd degree heart block. The person who wrote about the athletes, yeah, you must know about this. They keep mentioning this young lady with it, that she does a lot of sport. And it's completely normal. The question is what to do with her. Nothing. The answer is nothing. Do nothing. So 2nd degree AV block, we have the Mobitz type 1 and the Mobitz type 2. The Mobitz type 1, it's also called Winkebach. There is this lady on YouTube, maybe you saw her. Winkebach lengthening. Winkebach lengthening. So Mobitz type 1 has lengthening, Winkebach. It has a progressive lengthening of the BR interval until a beat drops. Okay, and basically this lengthening, we have lengthening of the BR interval, then further lengthening of the BR interval, then more lengthening of the BR interval, and then we have a drop. So it's usually asymptomatic, and there will be a variable RR interval with a pattern. So it means that it's regularly irregular. What does that mean? Let me explain for you guys. It means that, let's say that you have here one complex. Okay. Then you had this thing. Okay. Now another complex. Then another complex. Well, I'm bad at drawing. So anyway, to make it simple, I know what to do. Oh yeah, come here. Ah, I consider that as cheating. Okay. So, you can see here we have the what? We have a progressive lengthening of the BR interval. So here it is, actually this is a bad picture because this is supposed to be here, yeah? And there is lengthening of the BR interval basically. So the BR interval, guys, if you remember, it was from the beginning of the B wave until the beginning of the R wave, until here. So this is getting lengthened. And after some times there will be a missing wave. If we take a look at it here on an ECG, you can see like BR interval has this size now. So if you count, it's like 1, 2, 3, 4, 5, 6 small boxes. Well, that's normal. And no, sorry, this is abnormal. Normally it should be less than 5 small boxes. And now it has become even worse. 1, 2, 3, 4, 5, 6, 7, almost 8. Then it becomes 1, 2, 3, 4, 5, 6, 7, 8, 9. And then there is a drop. Then this exact same pattern repeats. And then the exact same pattern repeats. So lengthening, 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 drop. Lengthening, 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 drop. So if it was like after 3 lengthening you have a drop, it will be always like this. 3 lengthening and 1 drop. So it's totally irregular because the shape of it is irregular. It's getting lengthened and the RR interval is lengthening, which makes it like some form of irregular, but it happens in normal rhythm type of thing. Like it just keeps recurring at the same type of level, and that makes you think that it is regularly irregular, we call it. Okay, so it's regularly repeating and it's irregular by the shape. So they write variable RR interval with a pattern of regularly can first degree progress to second degree. Yes, it can. So variable RR interval with a pattern, regularly irregular. Does it need the treatment, Mobitz type 1? Well, in reality, mostly it does not, but except in one case, if the patient is symptomatic. And if the patient is symptomatic, what can you give for its treatment? In general, we don't treat it, except if symptomatic. If he's symptomatic, what is the drug we give? Starts with an A. I like this answer, antiarrhythmic, but no, seriously, which drug? Not Amiodarone, it's possible though. Atropine, excellent, it's atropine, guys, you must know this. So, the Mobitz type 2, there will be a drop beat, but it's not preceded by any change in the length of the BR interval, which means BR interval is regular. It's lengthened, but it's regular from 1 to 1. So it's like lengthened, boom. So it's fixed type of thing. There is no lengthening. So it's basically just like BR interval that is long itself, BR interval that is long itself, and then a drop the beat. So yeah, that keeps reoccurring. Okay, so it's a dropped beat that is not preceded by a change in length of the PR interval as in type 1. So here in Mobitz type 1 it was Winkebach, lengthening, Winkebach, but here is no lengthening. It may progress to a 3rd degree block and often treated with a pacemaker. Okay? By the way, guys, I know that some of you started doing U-word and you are facing a lot of difficulties with the vessels. The thing is, most of the vessels question you did not study yet. They are in the GIT, MSK, and the end of the CVS. So if you got these wrong, it's okay. I told you, you only have to get 30%. I just want you to start getting the feeling of your word. Do not get demoralized. It's okay. Just the beginning and just your baseline, whatever you got. But from here, you need to build up until you reach the highest score. So hopefully your first block, let's say you got 30%, and your last block you will be getting 85% or 80%. So we will see until then. Okay, how do you treat Mobitz type 1? Atropine, exactly. Good. And if atropine does not cut it, what do you have to do? Should we give a pacemaker or a defibrillator? Pacemaker. Which disease gets a defibrillator? We spoke about it. Well, ventricular fibrillation, it gets like an actual defibrillator right now, but I meant to ask which disease get an implantable defibrillator? Yes, it's Brugada syndrome. And can someone tell me where exactly do I see changes on ECG in the Brugada syndrome? Which leads? B1, 2, 3. Okay, so I will see right bundle branch block, a pseudo right bundle branch block, and an ST segment elevation. Great. Okay, so before going to the third degree heart block, I want to show you a trick that I personally use, because if I don't use it, I cannot diagnose any ECG with a Mobitz type 1 or type 2 defect. So what I do, they give you the picture of this ECG. So you take a look at it and you are like, what the hell is this? So you take it, you just enlarge it, and you can actually, it's possible to do this in your real exam, guys. And it goes something like this. You have to do the following. First of all, see all of these leads? You start with a B wave. You are like, okay, B wave, come here. Okay, B wave, oh, she's far away. Well, there's a prolongation of that. Well, I'm suspecting that this patient has some form of heart block because the BR is prolonged. So what should I do? I go to the longest lead they provide you. In this case, it's which lead is this one. Look down here. So they provided us with a really long lead. So if this one is really long, I go down and that's the one I'm going to work with. So BR interval here. Is it long? Let's count. So it's 1, 2, 3, 4, almost 5. 5 is long. Okay, so let's take this and put it here. Oh shit, this one is even longer. See, there is one more, one extra small box. 2 extra small box. Okay, just let's hold this, put it here. 2.5 small boxes. And then, well, a lot of small boxes, but wait a second. Where the hell is that QRS complex? It has dropped. So there was lengthening and then a drop. It's Mobitz 1 or Mobitz 2? 1, exactly. Good. So let's take a look at this one. That's a bit tricky. Okay, let's see. So this person, you take a look at this lead. It looks like the BR interval will be prolonged if you count the boxes, but let's do this. We enlarge, we go down here. Oh shit, this patient has 2 pathologies. It's too complicated for you guys. I will not do this to you. It's too much. But if you want to know for your own knowledge, basically this patient has a P wave not related to the QRS complex. So this is a complete block. So, but this is not for now. We did not explain it. We don't have to know it for now. So let's take a look at second. Yeah, exactly. It's a 3rd degree heart block, but I did not explain it yet, so I cannot ask you guys about it. Okay, let's say that the patient had constant PR interval prolongation and then he had a drop, which means that the PR interval was wide but regular. That makes it a type 2. So I want to show you a type 2. As I told you, you always take which one? The longest one they give you. So in this longest one they give us, in this case, you can see that there is the longest one. And if you take a look down there, you can see that, okay, this is the BR interval. It's wide, little bit wide. Come here. Okay, it's, if you compare this one with this one, it's kind of the same. Even if you get a ruler and you check how, like 3 small boxes, 3 small boxes. It's exactly the same. But then there's here something missing. Yeah? What is missing? The missing is basically a wave. Why it's missing? Because of the Mobitz type 2. Excellent. How do you deal with this? How should you treat it? Which drug should you give? Look guys, in general in the USMLE, you always think sheep and you always think less invasive. So pacemaker will do it, yes, but first of all you have to give atropine. If atropine will not cut it, you will do a pacemaker. Just always think about saving money for the health system. That's first thing you need to think about, and the second thing, less invasive for the patient. So yeah, okay, next thing. So we have the following. We have the third degree heart block. The third degree heart block is when the atria and the ventricles beat independently from each other. So the P wave and the QRS complex are not rheumatically associated, which means that the P wave does not always precede the QRS complex. It does not have to. And the QRS complexes are not rheumatically associated. So yeah, BR and QRS complexes are not related to each other. But the atrial rate will be more than the ventricular rate. A really smart person now will tell me why. The atrial rate is much more higher than the ventricular rate. Because each one of them originated from something different. Exactly, the SA node is faster. Exactly, good. So no conduction, so the SA node will contract the atria and the AV node will be contracting the what? The ventriculi. Actually, they like to call it the Hess bundle type of apparatus, the Hess bundle apparatus, and that controls actually the ventricle. Okay, and next we have, oh, what is the treatment? Guys, do not let them trick you with this one. You cannot give atropine. You have to give a pacemaker. And quick question for my A student, which is all of you. If you take a look at the heart like this, and I want to put a pacemaker, okay? So I insert a pacemaker transjugularly, I put it inside of the right heart. Should I put one lead here and one lead there? Or should I put only one lead? 2 leads or 1 lead? 2, exactly, because it has to be providing electricity for both of them, and it needs to be synchronous with each other. Yeah, that's the problem, absence of synchronism. Sometimes even you add a 3. Why you would add a 3? Because guys, think, how big is the left ventricle? Sometimes you add a 3 because you actually need more electricity to provide for the left ventricle. One lead for the left ventricle will not cut it. You need more. And thus you must add more leads. But you don't have to know this exactly, but what I want you to know that it need to be synchronized with each other. That's the main thing. Okay. It can be secondary to Lyme disease. Can someone tell me which stage of Lyme disease will have it? Is it the first stage, second stage, or the third stage? Third stage. Good. How do you treat it? Oh, someone got it tricked. Excellent. Excellent. One more person got it tricked. Excellent. One person got it correct. So they love to trick a student with this. They give them the Lyme disease question, and the definitive treatment is actually the antibiotic. If the patient is stable, you don't have to give him the pacemaker. If he's unstable, well, yes, but if he's stable, you don't have to give the pacemaker. You instead just give an antibiotic. But which antibiotic will you give? Let's just see people who get it tricked again. Which antibiotic you will give for Lyme disease to treat an AV block, complete heart block? Well, yes, it's ceftriaxone. A lot of you guys maybe know that doxycycline is used for the treatment of Lyme disease. and it's used for the treatment of mild Lyme disease, okay? But if a person has a third-degree heart block, you need a big gun. You need to deal with him with a drug that is really potent. A drug that is really potent is ceftriaxone. Guys, when you look at an ECG and you find a P wave overlaying a QRS complex, done. Don't look even more. You already have the diagnosis. This is a complete heart block. Why? Because never ever you should see a P wave on a QRS complex. This is just abnormal. In this case, if you look here, there is a freaking B wave and a T wave. Normally this should not happen, but since everybody is beating at his own time, you can see it. By the way, a quick fact, I will show you. I will show you a quick way to deal with it, which is basically you just take the ECG, you put it in front of you, you bring a ruler, you take it, so yeah, you can see even here, if you notice, you can see the P wave is hijacking the QRS complex. But easier way, you just take a ruler, you measure the distance, then take it again. You can see the RR interval is actually regular, guys. Yeah, it's regular, the RR interval. Okay, so the RR interval is regular. So the second thing you have to do is to check the BB interval. Yeah, so BB interval. Oh, where is it? It's hiding inside of it. Yeah, and okay, why the RR interval is regular okay, so the idea here, it's like this. Look, if you have the atrium and the ventricles, okay, and you have the conduction system, it's normally go from here, then goes there, and then it goes do all of the job. Like here we have the bundle of hairs, and here we have going like this. And let's say someone got an AV block. So still the atria will be able to contract the atria, no problemo. So the PP interval will be normal, yes? Because they are contracting at normal rhythm, which is the rhythm of the SA node, which is which has the rate between 60 to 100. Okay, what about the poor ventricle? The poor ventricle is not getting anything from the AV node. So he has to use what? The Hess bundle. So it uses something called the Hess-Purkinje system. Okay? Hess-Purkinje system. The Hess-Purkinje system allows a constant heart rate and heart rhythm for the ventricles. So inside of your heart becomes two different hearts, basically two different pumps. Each one works alone and there is no communication between them. Yeah, so everybody does whatever he wants, and that leads to a big problem in your heart, because everybody does his job but they have no connection. So if they have no connection and no diplomatic relationship between them, that can lead to a big failure. This is basically Cold War type of thing. Okay. So I hope it makes sense. And now we go back here. The treatment of this condition is pacemaker. So the last thing before the break, you can see here the examples. Can someone tell me which one goes counterclockwise and which one goes clockwise of this AV re-entry tachycardias? Which one is counterclockwise? Orthodromic. What about the antidromic? Someone asked because the ventricles are yeah, based by yes, or his bundle. Orthodromic. Okay, guys. If it is going counter, it's mean like opposite. If it's counterclockwise, it will be anti. If it is clockwise, it will be ortho. Okay, so You can see it like this. Remember, clockwise, ortho. Counterclockwise, anti. Keep in mind of one thing though. If you have everything is positive, it's antidromic. If you have any like retrograde B wave, see this retrograde B wave? If you see retrograde B wave, done. Oh, I like this, anti-clockwise. So if you see this like B wave inverted, like backward, retrograde B wave, this is orthodromic. So this picture you should do, and I personally I added this picture and printed this picture and put it in my room because they do ask this question and you must know about this question. So I just sent it to you, and yeah. Okay, let's have a little break now and we'll continue after the break. So we'll come back at 7:11. Okay, welcome back, guys. So let's take a look at a few chest x-rays really quick, and you guys try to tell me what it is. What it is? Any idea what this chest x-ray? Oh, someone knew it right away. Cardiomegaly. Do you remember, guys, when I told you about the midclavicular line and that the heart should be right to the midclavicular line, 2.5 centimeter right to the midclavicular line? If you take the midclavicular line here, go down, oh, it's to the left of the midclavicular line, which tell you the patient has cardiomegaly, correct? What about this one? What does he have? Exactly, tetralogy of Fallot. Which, how does it look like? Exactly, the shoe, the boot. It looks like a boot. Okay, what about this one? How do you are correct, but can you tell me please, how do you know that this is like supraventricular tachycardia and not ventricular tachycardia? Narrow QRS, excellent. Oh, this is too small. Bad equality, but this is also an SVT. Okay, the last one. Why it's not Torsades de Bois? Awesome. Yes, exactly. If you make it's like the RR interval are at the same level. Okay, the R waves at the same level. Okay, good. Now we go back to first aid. So these are respectively as follows. So if we go back to them, cardiomegaly, tetralogy of Fallot, SVT, supraventricular tachycardia. This is also another one, but the quality is bad. And this is ventricular tachycardia. Not tetralogy of Fallot, because tetralogy of Fallot will be going up and down, but this one is straight. Since it's straight, the R waves, it's not tetralogy of Fallot. But it's ventricular though, because the QRS complexes are wide. Okay. So someone told me to explain something, but I just forgot where it is. Yeah, here it is. Yes. Someone says, what is the difference between the pacemaker, cardioversion, and cardiac defibrillation? Good question. So, cardiac defibrillator is like one shot time. It's like this. Let me show you. So, this machine that there is two types of it. There is like an implantable one, and there is one that you use like a defibrillator. You use, oh yeah, that one, the old school one. Okay. And there is the implantable one. Yeah, there is this one and the implantable one. So this does not chronically make like little pulses. It just make yeah. So it just make like constant. It does not make constant impulses. Instead, it just do what? It has like a little ECG machine inside of it. And the moment that it sends that the patient heart has stopped and he's having like ventricular fibrillation, it starts working. It pushes electrical shocks until the heart starts working again. When the heart starts working again, the defibrillator stops working. While the pacemaker is constantly working 24/7. So it keeps working. It looks kind of the same, but instead, as you can see, there is one in the atria, one in the ventricle, sometimes two in the ventricles. And the idea that it's constantly working all the time. Why? To make the rhythm always correct, okay? And now I have the question that as a future resident, you will be asked. Guys, you know these bats? Like they touch them with each other on movies and all of this Hollywood movies and serials. They touch them to each other and start rubbing them against each other. Do you know why? Before they shoot somebody, they take these pads and they start like rubbing them against each other. Oh yeah, that was my answer. It's wrong. It's not related to electricity. Actually, what happens that on the bats, you are not allowed to do that. Okay, look, on the bats, you put jelly to improve the conductiveness. Imagine you are defibrillating a patient who's really hairy. It will be impossible to reach that. So you put some form of jelly, like a liquid, and then you want to spread it. How do you spread the liquid? You just put them against each other and you spread the liquid, and after that you shock. Okay. Currently now there is this like different structure for this. It's just like a blaster. You put it one time thing and that's it. But yeah, stickers, yeah, stickers are better. Okay, good. So let's take a look here, and now we are going to speak a little bit about atrial natriuretic peptide. Oh, wait, I cannot speak about that before giving you guys the algorithm. So there is an algorithm that you need to follow when you deal with the ACG. So here we have the ACG, and there is a little bit more in the future we will see regarding the ACG, but that will be about ischemia and this stuff. But I will give you the algorithm now, and I will give it to you again when we reach it. Number one. The first thing you do when you look at an ECG, let's just grab a normal ECG. And yes, so this is a normal ECG. You put it in front of yourself. The number one thing you need to check, make sure that in the AVR, see this AVR, this is number one thing. Make sure that the B wave and the QRS complex and the T wave are all negative. See, B wave is negative, QRS complex is negative, and T wave is negative. What does that mean? It means that you have installed the machine, the ECG machine, correctly. If any of these is positive, it means that you have put in it like upside down, basically. You put the leads in the wrong place. So after you look on this, you see all of them are negative, you are like, cool. So I know that I have put in it on the correct side. So what is step number two? Step number two is to look at lead number two. Remember, the lead for newbies, for people who, yeah, cannot deal with the ECG really good like me. So You can see here the B wave, you can see the QRS complex, and you can see the T wave. So the step number one, I hope somebody is writing these. If you can write it in the chat, it will be great. Step number one, you check the AVR. All of the waves should be negative. Step number two, B wave. B wave should be present before the QRS complex. So you look at the QRS complex and you check the wave before it. Okay, step number three. It's different from book to book. On step number three, some people say check the PR, some people say check the QRS first. Personally, I do the QRS first. So you check the QRS complex. What are we checking him for? Two things. The first thing in step number three, which is checking the QRS complex, you are checking for, is it narrow or is it wide? Yeah? And if it was narrow, you know that the patient has his impulse coming from the atria. If it is wide, it's from the ventricles. Number two, you are checking the QRS complex, its voltage, and you also are checking his rhythm. Why? Guys, notice here. The voltage here, it's like almost one big box length. But let's say it was really, really small. It means that the patient electrical activity is really, really bad. If the electrical activity is really, really bad, I'm basically telling you the patient could have heart failure, previous ischemia or current ischemia, and all of these will lead to the heart like contractility function being messed up. Step number four, you finish checking the QRS complex. So after checking the QRS complex, you check the PR interval. PR interval, this guy. You are checking if it was short or long. If it was short, which disease are you thinking about? Write me in chat. If you have, yeah, okay, well, Parkinson-White syndrome. If it was long, which problems are you thinking about? AV blocks, awesome. Okay, so step number 5, okay? So step number 5, we finished with what so far? We finished with the B wave, we finished with the QRS complex, we finished with the BR interval. So we have two things left, the T wave and the ST segment. Guys, I know it sounds so tempting to go to the ST segment right now. Oh, I'm sorry, we forgot one more really important thing. QT interval. So we check the number 5, yes. Number 5 is QT interval. What does it mean if the QT interval is really long? That predisposes you to get what? If it was long, it means that it's possible for you to get torsades de bois or torsades de points. Electrolyte disturbance, keep it for later, we'll study these alone. But yeah, you are right actually. The last thing, hypocalcemia, hypokalemia, and hypomagnesemia. Awesome. So step number 6, so you finished with the QT, we are left with the ST segment and the T wave. Guys, this is an important step. A lot of students go straight to the ST segment the moment they handle an ECG. The reason is that the moment they see an ECG, they keep thinking about what? They keep thinking about MIs. So you must check the T wave before the ST segment. Do not check the ST segment before the T wave. Why? Because the algorithm says so. Okay? Why the algorithm says so? They discovered that physicians tend to look at the ST segment much more often than looking at the T wave, and that leads them to miss so many pathologies located in the T wave. So then step number 6, T wave. Checking T wave. What does it mean of that if the T wave was absent or flat? Potassium is what? Hypokalemia, exactly. So potassium is low. Okay, what does it mean if the T wave was prominent? Hyperkalemia will do that. Ischemia will do that. Good. Guys, now it gets tricky. What if it was inverted downward? So here is the thing. Some of you said a prominent ischemia, inverted ischemia, and both of you are correct. So how come it can be inverted and it can be prominent at the same time? Take a look here. This is the progression of MI. So if you can see here, we have like B wave, and voila, the B wave is elevated. Yeah, sorry, T wave, what I'm saying. So T wave is elevated. So that's correct. So it can be prominent in case of MIs. If you have a persistent progression of the MI, ST segment elevation happen, then you have T wave inversion. So it was elevation, then inversion, elevation, inversion, acute, chronic, acute, late, acute, late. Okay, good. Next. So back to this guy. You are done with the T wave. The last thing you must do is to check what? ST segment. Okay, the ST segment you need to check. And the ST segment, when you check it, you need to be careful about something called what exactly in the ST segment. What is the first point in the ST segment, guys? It has a name. Not I, but it's J wave. J, exactly, J wave. J point, not wave, point, yes. Okay, gotcha. So J wave, J point, it's at the beginning of the ST segment. So you take a look at it and then you make a line, always. So somebody writes signs of ischemia is both high T wave and inverted T wave. High T wave, it will be acute ischemia. Inverted T wave, it is late ischemia. It depends on the time. Do not let these guys trick you in the exam, guys. So now let's take a look at a STEMI to know how we can suspect an MI. This is why you enter medical school for, guys. So if you take a look at the STEMI, and yeah, let's look at a full 12 lead ECG for this. Want something that when I open it will not be total crap. Yeah, this one is good. So guys, this picture, you go to lead 2. What is the first step? B wave. Then you check the QRS complex. Then you check what? QRS, PR. Then you keep moving forward. After finishing with the PR, you have to check the QT. After checking the QT interval, you have to check the T wave. After checking the T wave, you have to check the ST segment. So you are done with the ST segment. Now you are at the ST segment. So you go with this, going with the flow. So you go with the SS first of all. So QRS, you are at the S. And at the end of the S, yep, come here. At the end of the S, here, you make a line, guys. Always make that line. Good. Make it isoelectric. Is this line lower than the PR interval or not? Yes. So it means it's an ST segment elevation or depression? Depression. Okay. The same exact thing. Let's play it, but on a different lead. Okay. So that was easy because that lead you know, guys, but let me give you a totally different lead. This is lead number 3. So you guys know this is what? QRS. Yeah, so this is S. It is lower than the PR interval or not? Is it lower than the PR interval? Yes, so it is a ST segment depression, myocardial infarction, also called non-STEMI. Good. But here it becomes tricky a little bit. Okay, so let's take which lead? Oh yeah, let's take this lead. Here it gets confusing. So you take this one, you make the line, and it's higher, yes? Since it's higher, it tells you that this is a STEMI. You are like, wait a second. Is it a STEMI or a non-STEMI? Now I'm confused. How can one ECG have both? This one as well. This is the J point. If you draw like this, it has both. It is a STEMI basically, yeah, because it's higher than it. Well, basically, look guys, the lead 2, 3, AVF, I will tell you in the future that they represent the inferior wall of the heart, okay? And basically they are answering a person who's having a myocardial infarction in his anterolateral wall, which you can see the lead affected here, 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 and also here and here, okay? You don't have to know this now. I will be explaining you in the future, but just now trust me on this. If you have a STEMI in one wall of the heart, the wall on the opposite side, if this was elevation, the wall on the other side will be depressed, okay? So if the anterolateral wall will be STEMI, the inferior wall will be non-STEMI. We'll be speaking in the future how exactly reciprocal changes. We'll speak in the future how exactly each one of these leads respond to which exact electrode. Okay, so that's it for now. I hope you guys got that algorithm and I hope it's helpful. Now we are going to speak about the hormonal function of the heart. So from the heart we have secretion of two hormones. The first hormone is called A and B, the second hormone is called P and B. So the A and B is basically the atrial natriuretic peptide, and thank you so much for the photo. And atrial natriuretic peptide is secreted from the atria. Guys, please know this. If I draw a heart for you like this, and up here is the atria, down here is the ventricles, you must know that the A and B is from the atria, the B and B is from the ventricles. So the A and B is released from the atrial myocyte in response of increased blood volume and atrial pressure. Let me explain actually how it's released. So if you have a heart chamber here, like the right atrium, for example, okay, and you have a lot of blood in it, the walls will be distended. When you distend the wall, the hormone will be released. So it will be released in states of hypervolemia, okay? If your patient has hypervolemia, this hormone will be released. Is it good or bad to release that hormone? It's really good. Okay, so again, there is inside of the wall of the right atrium, there is basically sensors, okay? And these sensors sense the stretch. And if you have a lot of blood going inside of your right atrium, the walls will be really stretched. Yeah, it's like a balloon and you inflate it with a lot of water. Yeah, it will be really stretched. So when it becomes really stretched, the hormones inside of the wall will be released inside of the circulation. This hormone, we call it ANP. Atrial natriuretic peptide. This atrial natriuretic peptide has a really important job, which is natriuresis. We'll speak about it in a moment deeply. So it acts via the cyclic GMB. Sadly, you have to know this. I will be sending you a mnemonic to memorize all of these. But basically, you have to know that it acts through cyclic GMB, and that can lead to vasodilatation. Okay? So, is vasodilatation a good thing in a patient who is hypertensive with heart failure, for example? Exactly. It's an amazing thing. It also decreases reabsorption of sodium and renal collecting tubule. So, if it decreases the reabsorption of sodium, you will have more sodium inside of your urine. What will happen to the osmolality of the urine? Osmolality will increase because the higher the amount of electrolyte inside of your urine, the higher the osmolality of the urine goes. Yeah. So dilate, and also the A and B works at the kidney. It dilates the afferent arterioles, renal arterioles, and constrict the efferent arteriole, promoting diuresis and contributing to the aldosterone escape mechanism. Let me explain this. So, if we draw afferent arteriole, glomerulus, efferent arteriole. You know this annoying picture of the heart I keep drawing for you? Now this is the annoying picture of the kidney I will keep drawing for you. So this is the afferent arteriole, glomerulus, efferent arteriole. So if the A and B get released, this guy come and tell the afferent arteriole, can you please dilate? So this guy dilate. So what will happen to the perfusion inside of the glomerulus? What do you think, guys? The blood, there will be more blood or less blood? Exactly, more blood. So there will be more blood going inside. In the same time, the A and B will go to the efferent arteriole and tell him, can you please constrict? And he constricts, so it becomes smaller. So what will happen to the intraglomerular pressure? What will happen to the pressure inside of the glomerulus? Increases. Good. If the pressure inside of the glomerulus increases, what will happen to the filtration? Increase. The filtration will increase, guys. It's like you are constricting from here, so you have a backup of blood here, and this blood is secreted extra here, so the intraglomerular pressure will be skyrocketing, and there will be more stuff excreted outside. Exactly. So the clearance will be high. The filtration rate, the filtration will be high. In the future, I will be teaching you what is the renal plasma flow, what is all of that. That's for later. But for now, I want you to know that the clearance will be higher. Okay? So, good. Let's see what they write. It dilates the afferent arteriole and constricts the efferent arteriole. Now it makes sense, guys. That promotes diuresis and contribute to the aldosterone escape mechanism. What is the aldosterone escape mechanism? I will explain it once now. I will explain it once when we do endocrinology, and I will explain it again when we go to renal. So, if you get it from the first time, you save yourself a lot of time. So, aldosterone escape mechanism. When the aldosterone inside of your body is high, where is aldosterone secreted from? Someone tell me really quick. The adrenal, which zone of the adrenals? Not the medulla. Where in the cortex? Okay, look. So here is the thing. The cortex has a three layer. One called glomerulosa, the second one called fasciculata, and the last one called reticularis. And you have the medulla in the middle. So the medulla actually secretes epinephrine and norepinephrine. That's it. But the glomerulosa, fasciculata, and reticularis, each one of them secretes another substance. How the hell I can keep them in order and not forget them? Guys, it's the adrenal gland. It's above the kidney. I just tell myself it has this GFR. Remember the glomerular filtration rate. So GFR. The deeper you sweet, the sweeter it gets. What does that mean? The outermost area secretes mineralocorticosteroid. Minerals, guys. Minerals. Minerals, it's like the thing you use as a salt in your food. Minerals. Mineralocorticosteroid. If you go a little bit deeper, it becomes glyco, it's like sugar, glycocorticosteroid, okay? So from the fasciculata, you have a glycocorticosteroid. And the deeper you go, the sweeter it gets. So the last one will be actually 6 hormones. So 6 hormones like testosterone and estrogens, they will be from the reticularis. The question comes, why they named them like this? Sadly, and I'm sorry to tell you this, but you must know the adrenal histology for the USMLE step 1. But I will try to make it as easy as possible. Guys, notice here, the outermost portion of the adrenals has a glomerulus-like structure. See this little black structures? In the fasciculata is a glycocorticosteroid, which is like cortisol. Glycocorticosteroid. So you can see here we have like little glomeruli all over the place, like the one in the kidney. It should not have glomeruli in a gland, because they are not. They look like glomeruli, but they are not. But we call it glomerulosa. So this was secreting the mineralocorticosteroid. The fasciculata, it looks like fascicles, which are like strings, okay guys, or ropes. It's just straight like this, if you can see it. And these are basically secreting the what? Fasciculata secretes the glycocorticosteroid, like cortisone, cortisol, all of these guys. Finally, the reticularis, which is the innermost portion, it looks like a net. And since it looks like a net, and it makes what? It makes the sex hormones. Okay. And if you take at a gross picture of it, it looks yellow. Why it looks yellow? All of the hormones I just mentioned, are they cholesterol hormones or protein hormones, or what are they? Or peptide hormone? Cholesterol, and cholesterol is yellow. So that's why the adrenal gland is yellowish. Okay, good. So guys, what is the aldosterone escape mechanism? You told me that the aldosterone is made in the zona glomerulosa. The aldosterone reabsorbs sodium and excretes potassium. If you don't know this, now you know. It reabsorbs sodium, excretes potassium. And pretty soon we'll speak deeper about this. But for now, I want you to imagine, if you have more sodium inside of your circulation, what will happen to your blood pressure? Yes, what will happen to the volume inside of you? Increase as well. Good. And you will become hypervolemic. And if you become hypervolemic, your right atrium will be distended, correct? And that will lead to the release of, yes, because of the increased venous return. And that will lead to increased secretion of atrial natriuretic peptide, because we just said that dilatation of the right atrium releases the A and B. Yes, exactly, the stretching. And if you have a release of the A and B, that leads to vasodilatation, which decreases the blood pressure and also lead to decrease in the reabsorption of the sodium. So your sodium level go back to normal. So someone who has chronic hyperaldosteronism have normal volemia and has normonatremia. Why? If they ask you, because of the aldosterone escape mechanism. What is that? It's what we just explained, and it's due to the release of the A and B. Does it make sense, guys? Awesome. Awesome. Good. Happy to see that. Okay, if it does not make sense, I will be explaining the exact same thing in renal and again in endocrinology. So the BNB, the B-type brain natriuretic peptide. For the first second you see this, you are like, what the hell? Why is brain in the heart? It does not make sense. Well, actually, guys, it's weird, but I read about it. It's basically the first time they isolated this hormone, it was in the brains of rabbits, and that's why they call it like the brain natriuretic peptide. And it's an outdated name, and they don't use it anymore. But for the sake of like, I don't know, party talk, it's for the reason I just said. So it's the beta type natriuretic peptide. It's released from the ventricle myocyte in response to increased tension. It's exactly secreted like the A and B. Similar physiological action as the A and B, but it has longer half-life. So if it has longer half-life and it stays for a longer period of time in your circulation, it seems like it will be a better diagnostic tool to utilize. So the BNB blood test is used to diagnose heart failure. Yeah? Why? Because someone with heart failure, he will be volume overloaded. And if he's volume overloaded, he will have more A and B and B and B, correct? And if that is the case, think about it. More A and B, B and B. A and B, it has short half-life. That will, you can miss it, you know. But B and B, since it has a longer half-life, you can always get it, like see it in circulation. And it has a very good negative predictive value. What does it mean, really good negative predictive value? It means if the test was negative, there is a really high chance that it's truly you do not have the disease, okay? So negative predictive value means if the test tell you that it's negative, it is highly likely that you truly do not have the disease. Well, speaking about biostat, it will be the topic that will annoy you the most. It's available in recombinant forms. It's called Nitriuretic for the treatment of heart failure. So they discovered, they were like, okay guys, if this A and B and B and B are really good for us, why cannot we just make them like we make insulin, for example, you know? So they were like, well, sounds like a good idea, let's do it. So here you can see the function of A and B. You can see it's released from the heart due to intracardiac filling pressure increased, and that increases your GFR. We spoke how afferent vasodilatation, efferent vasoconstriction. We said it decreases the reabsorption of the sodium, and lastly, it decreases the renin. If you have less renin, less RAS system activation. If you have less RAS system activation, you have less sodium. Okay, now since we are done with the hormonal function of the heart, let's speak a little bit about the baroreceptors and the chemoreceptors. So I want you to know, where is the heart center located in our brain? Can someone tell me? Where is the circulatory center located in our brain? Come on, guys. Two for medulla, one for bones. Let's see what the fifth person says. So medulla wins. Medulla wins. What about the bones? Well, bones actually, it's near it, but it's not exactly at it. It's actually from the medulla, okay guys? And the bones actually has the second nuclei, which is responsible for the respiratory center, okay? So you must know about these two. So in the medulla, you have respiratory and circulatory center. In the bones, you have only the respiratory center. Do not confuse this. Okay. So the receptors that you have inside of your body, you have different types. You have the ones in your aortic arch, you have the ones in your carotid, you have baroreceptors, and you have your chemoreceptors. We'll be speaking about all of this. So your receptors, aortic arch transmits via the vagus nerves to the solitary nucleus of the medulla. It responds to changes in the blood pressure. So what does that mean? Inside of your aortic arch, you have some receptor. Are they baroreceptor or chemoreceptor? Both. Guys, it's both. So you have both receptors located in your aortic arch, and when they get any info, like let's say they found that you have increased blood pressure, they are like, ooh, he has increased blood pressure. Vagus, king of night. And he will be like, what do you want, my son? He'll be like, can you tell Mr. Medulla that we have increased blood pressure? Be like, okay, sure. So he tells the medulla. So the medulla is your center for knowing what the hell is happening with the heart. So the knowledge you get from the receptors inside of the aortic arch, it goes to the vagus nerve and then it enters the medulla. Makes sense? And it responds to the changes in blood pressure, for example, and also it can be affected by like increased CO2, decreased O2. So these are important as well. Please guys, do not make the mistake that a lot of students make. If we're speaking about the aortic arch, the nerve that gets the sensation, it's the vagus. The nerve that it's getting the information is vagus. In contrast, if we are speaking about the carotid sinus, here, the carotid sinus, so they write you, it's the dilated region at the carotid bifurcation. If you want someone to faint, just massage this. He faints. It's cool. I know. Don't do it at all. So it transmits the info via the glossopharyngeal nerve. Okay? So you must know this actually. It's 9 nerve, not 10 nerve. It's 9 nerve, not 10 nerve. There is 2 word equation about it. Okay. And where it takes the info? Like always, to the medulla. Where exactly in the medulla? Like always, to the solitary nucleus. Okay. And it also can respond to the blood pressure changes or to the basically O2 changes and the CO2 changes. So you got the info from the aortic arch and you got the info from the what? You got the info from the carotid sinus. It goes to your brain, to your solitary nucleus. What's next? Response. Response can be either sympathetic or parasympathetic. So the afferent system here is done. Now the efferent, what goes out. You have parasympathetic and sympathetic. I want to check your knowledge really quick. Can someone tell me please, can sympathetic leads to vasoconstriction or vasodilatation? Sympathetic, vasoconstriction or dilatation? Okay, yes, it leads to vasoconstriction. Okay, does it lead to tachycardia or bradycardia? Really quick, I just want to check, like, should I explain that from zero or not? Okay, good. What about parasympathetic? Does it lead to bradycardia or tachycardia? Okay, good. So yeah, well, since you already guys know what is this, we can like skip explaining what is autonomic nervous system. We'll do it when we do pharmacology. So first of all, you have something called the paravertebral chains. I want to show you the paravertebral chain. So this paravertebral chain of ganglia are like yes, can you see this paravertebral chain of ganglia? It's basically like a center that moves sympathetic activity from the CNS to the PNS. So yeah, it's located paravertebrally, like near the vertebra, but not at the vertebra. Okay, good. So what happens is the information comes out from the medulla to the spinal cord to the sympathetic chain. You must know this, and you must know that it's sympathetic. And then sympathetic nerves exit and they go to the blood vessels leading to vasoconstriction or dilatation. Constriction, okay. And they go to the heart and lead to tachy, exactly. So they affect both the SA node and the AV node. In the parasympathetic, it mostly does not affect the vessels. Can someone please tell me which receptors do you have in your vessels? Alpha 1, what else? No. I mean like which receptors, I mean in a sake of like alpha 1, alpha 2. Okay, so alpha 1, beta 2 and so mostly not. It's alpha 1 mostly and beta 2 and M3. A lot of students be like, no, wait. It's wrong. M3 is not located in the vessels. Well, actually guys, it's located there, but it's not, the M2 it's on the heart, but I'm saying about in the vessels. So the M3 is located in the vessels, but it's not active. It's not supplied by any of the it's not supplied by the parasympathetic nervous system to lead to anything. So why we learn it? Because if you give a medication that is a muscarinic agonist, it will affect the M3. And if it will affect the M3, it leads to vasodilatation. And if you give an antagonist to it, it leads to vasoconstriction. So that's why you be careful with it. So for example, if you give someone atropine, keep in the back of your mind that he can get inactivation, well, basically blockage of the M3, that's not a big of a deal. But if you give him physiostigmine, which is a muscarinic agonist, and it can work on that receptor, he will have massive vasodilatation. So keep that in mind. And that can lead him to get in a shock. So you need to know that you have alpha 1, beta 2, M3 on the vessels. Okay. So far so good. Let's speak about the baroreceptor. So baroreceptors gets activated in case, for example, of hypotension. So if someone is hypotensive, he has decreased arterial pressure. So less arterial pressure, there will be less stretching. And if there is less stretching, what will happen? Less stretching of what exactly? Of the receptor. Yeah? So there will be less afferent with the one going up, less afferent baroreceptor firing. That will lead, if you have less afferent, there will be, what about the efferent? It will increase. If there is, so look, the aortic and the carotid sinus want always to be on fire. He always want to be stretched. If he's not stretched, he'd be like, the patient is hypotensive. Medulla, the patient is hypotensive, start working. So the medulla, the moment that it senses the firing of the vagus or the glossopharyngeal nerve telling it that the blood pressure is low, it fires. So the medulla fires through the sympathetic or parasympathetic. What do you think? Oh, somebody wrote it already. Yes, the sympathetic. And the sympathetic will increase the firing while the parasympathetic will decrease the firing, and that leads to vasoconstriction. Okay, so you have vasoconstriction. Why? Because the sympathetic did this. You have increased heart rate. Why? Because the sympathetic did this and the parasympathetic had stopped its function. There is more contractility, and the smart person will tell me which electrolyte led to increased contractility. Calcium. Okay, and do you remember, guys, which receptor is affected by the sympathetic nervous system on the heart? Beta 1. And can someone tell me this beta 1 is coupled to G what? Is it GI, GQ, GS? Yes, it's GS, and since it's a GS, it activates adenylate cyclase, and in a patient who has an active sympathetic nervous system, there will be more cyclic AMP or less cyclic AMP. More cyclic AMP, which means the patient will have less ATP. If you have more cyclic AMP, what will happen next? You will have activation of two different pathways. The first pathway is the phospholamine, as it's what was written, which lead to calcium accumulation inside of what? Oh, yeah, protein kinase A will be activated. That leads to phosphorylation of what? The phospholamine, which accumulate the calcium inside of the sarcoplasmatic reticulum. Absolutely correct. What about the second function of protein kinase A? Has another function improving the contractility. It works on gas-based scales, man. So actually it also increases the amount of calcium entering the cell. So there will be calcium induced calcium release, remember? So we have the following. We have more blood pressure also as well. Why? Because we had activation of the sympathetic nervous system, and it's important in responses to severe hemorrhages. So the second thing you must know about is the carotid massage. So when you do the carotid massage, there will be increased pressure of the carotid sinus, which increases the stretch. Increasing the stretch will lead to more afferent baroreceptor firing, which will fakely tell the medulla that your blood pressure is high. It will trick your medulla to think that the blood pressure is high just because of the stretch. And there will be a high AV node refractory period, which decreases the heart rate. Guys, make a note. The carotid massage on the USMLE, They like to associate it with a synocopial attack, like the patient massages the carotid and get in a syncope type of thing. And they will tell you that someone wearing a tie, for example, like be careful, or buttoning his upper shirt. Like if they tell you he gets an synocopial attack when he buttons his shirt, or he got it when he was doing his tie, yeah, it is this one. Okay, so by the way, just for fun, guys, if you have a toothbrush inside of your mouth and you walk and you just drop, and that toothbrush go all the way to your throat and hit the back of your throat, that will injure your internal carotid artery. It's a U-worthy question, that's why I'm telling you about it now, but yeah, just for fun. Also shaving, exactly. So the next thing is about component of Cushing reflux. Okay, what is Cushing? Anytime you hear the word Cushing, think brain. So Cushing reflux is as follows. It's a triad because of increased intracranial pressure. Guys, when you have more intracranial pressure of the brain, what happens? The inside of the brain, you will have some like your sympathetic nervous system inside of your brain will be doing some stupid stuff. Okay, so these are the following. First one is hypertension. So you will have hypertension. I imagine it like hyper, hypo, hypo. So hyper, the first one is hypertension. The second, hypo, it's like hypocardia. There is no such thing, so bradycardia. And hyporespiration, which is like decreased respiratory depression, basically. So the respiratory and circulatory system goes down, like their heartbeat goes down, their respiration goes down, their blood pressure goes up. And there is one more thing. There will be high intracranial pressure, and when the high intracranial pressure, which is the cause of this triad, happens, there will be high intracranial pressure, which constricts the arterioles. When the brain feels constriction of the arterioles going into it, there will be cerebral ischemia, and the brain will be like, I'm dying, and then he will start secreting a lot of CO2, and there will be a state of acidosis inside of the brain because the processes of apoptosis and necrosis will start to occur. Super serious. That will make the central reflex sympathetic increase the perfusion pressure. How can they do that? Well, the brain is suffering, man. Send me more blood to the brain. How can I do that? Increase the blood pressure. So yeah, that increases the blood pressure, and when you have more blood pressure, that will increase the stretching of the receptor inside of your aorta and inside of your carotid. Yeah? If that is the case, it will fakely tell the medulla, dude, you have hypertension. So when he feels like there is hypertension, the medulla will, what will it do? It will start activating the parasympathetic nervous system, which lead to bradycardia and decreased respiratory rate. So the hypertension is basically central. The cause of it is central. And the bradycardia and the decreased respiratory rate is due to a fakely perceived decrease in the heart and the blood pressure. Yeah? Sorry, it's due to the bradycardia and the respiratory depression are due to the increased stretch, which lead to peripheral reflex baroreceptor. Okay, someone just joined now, so let me just let him enter. Okay, so moving back, we have the following. So chemoreceptors, it will be as follows. That's my dark mnemonics. So chemoreceptors, we have peripheral ones and we have central ones. So the peripheral ones, it's carotid and aortic bodies. They are stimulated by the BCO2, okay? And also by the state of acidosis and also by the decrease of the O2. All of these will lead to, what do you think? They will lead to activation or depression of the sympathetic nervous system. The increase in the CO2, So think about it, guys. If you are cannot take if you are in a really bad shape, you have your CO2 is really bad, you need to improve respiration, correct? You also have to improve what? You have to improve the pH of the blood. So the first thing that will be actually activated is what? Would it be the sympathetic or the parasympathetic or the respiratory center? What do you think? Variable answers, exactly. I like when it's variable. So the respiratory center will be absolutely activated to lead to the tachypnea. It's because you will learn in renal in the acid-base disturbances actually this exact concept. It's not cardiology, it's renal. And when the patient is in a situation in which he have high acid, the first thing that will be activated is his respiratory center. It will be giving a feedback, which can lead to, exactly, it's acidosis case. It increases your respiratory rate right away. While there is chemoreceptors also in your brain, but you need to keep in mind one thing. In your brain, mostly, it is about the CO2, not the O2. So, they write central, they are stimulated by changes in the pH and the PCO2 of the brain interstitial fluid, which in turn are influenced by the arterial CO2 as protons cannot cross the blood-brain barrier. So it is do not directly respond to the PO2. What does that mean? If you are in a state of acidosis, okay, like respiratory acidosis, let's say, the PCO2 will go to your brain and tell him, wake up, wake up, wake up. Start breathing, you are dying, man. But in case of decreased PO2 alone, that will not occur, okay? Actually, this is really interesting. There is one lady, really quick story, so you will not forget about this. There was one lady that they removed both of her amygdala. Anybody here know what is amygdala? What function amygdala has? You have to know it for the USMLE. Amygdala is a structure in your brain, and the function of it is your emotions. So if you remove someone amygdala, he become emotionless. Okay? So that lady, they removed both of her amygdalas. She did not have any amygdalas because she had cancer in them, basically. And afterward, she had zero emotions, no emotions at all. And she did not have fear as well, okay? She has zero fear. Guys, they tried to scare her in every single way, with her consent, of course, because they were doing studies on her. She's still alive, but her name is secret, not to be the press talk. It's a part of the limbic system, the amygdala, yes. And this lady, they tried to scare her in every single way. Nothing worked except one mechanism. They did this. They increased her CO2 in her blood while keeping the O2 level normal, which means she's still alive, but they only increased the CO2. She became frightened. It's the only way that she got really afraid. Why? Because she affected other central receptor inside of her brain that told her you are suffocating. So she went to one of these primitive reflexes that I wanna live, you know? So limbic system is kind of a developed system. Guys, when we speak about neurology, it will be really exciting with you actually. If you speak about an ant, no, not an ant, let's speak about like little insect. Do insects have feeling? Why they do not have feeling? They have a brain. They just do not have the limbic system. Okay, so do cats have feeling? Cats and dogs, do they have feeling? Yes, they do. Why? Someone got offended. He wrote sure. Because they do have limbic system. Okay. Now let's go to more developed animal. Do humans have feeling? Well, not all of them. Well, yeah, of course they have feeling, but what about cognition? Do cats have cognition? Well, cognition, I mean by the ability of realize your own life and making plans of the future. That's the definition of cognition. They do not have cognition. Only human beings have cognition, and a little bit dolphins actually. Why? Which structure we have, they don't. We do have something called a developed neocortex. It's our frontal lobe. Okay? The cover of our frontal lobe and all of our brain. Our neocortex is the most developed. Guys, the neurology will be super exciting when we study it together. I will make sure that you love it. You really like it. I will teach you it from a different perspective. So, okay. So here we go back. So they write, do not directly respond to the PO2. Central chemoreceptors become less responsive with chronically increased PCO2, like in cases of COPD, yeah? Like when they are really used to the CO2 being high, they stop caring too much. They get a process called anergy or habituation, in which like they get used to it. And there will be an increased dependence on peripheral chemoreceptors, to detect the decrease in the O2 to drive the respiration. What does that mean? Well, mostly your brain is controlled by the CO2, not the O2, okay? But if the CO2 is all of the time is high, for the blood that becomes the new normal. For your brain that becomes the new normal. So he started trusting the O2. But since you do not have a receptor for the O2 in your brain, he has to get this info from your aortic arch and your aortic sinus. Okay, good. So these are just your receptors, just basic concepts. It's not that difficult, it's not that bad. Guys, do you allow me to finish this page? Can I continue this page? Just to be done with physiology today. I really wanna. Oh, okay, yes. Okay, democracy, come on guys. Come on. I'm kidding, sure, yes. Okay, so let's go. Normal cardiac pressure. So normal cardiac pressure goes as follows. There is the rule of 5. So the rule of 5 tell you something like this. Come on. So 5. The first 5 is the pressure inside of your right atrium. 5 multiplied by 5 is 25. And there is another 5. Why? Because why not? Okay, now 5 plus 5. 10. What about this 25? Just put it. So that becomes the pulmonary artery. So 5, 25 on 5. And then 5 plus 5 is 10. And you put the 25. I hope you get it, guys. Okay, again. So rule of 5. 5 plus 5 is 10. 5 multiplied by 5 is 25. Done. Good. So the next thing you have to know is the blood pressure inside of your what? The BCWB, your pulmonary capillary wedge pressure. I'll be telling you now about it. Just give me a second. And it represents your left atrium pressure, which normally it's under 12. Lastly, I will be speaking about the left ventricle. It's 130/10, and the left and the aorta is 130/90. I want a really smart person to tell me what controls this guy, the diastolic blood pressure of the aorta. It's controlled by whom? Who controls the diastolic pressure of your aorta? Arterioles, exactly. Systemic vascular resistance. Good. Afterload. Awesome. All of these answers are correct. Good. So, There is something called the Swan-Ganz catheter. You have to see it to know what I'm speaking about. So the Swan-Ganz catheter, they love it in your word actually, that's why you should take a look at it. So Swan-Ganz catheter is this catheter that you insert from the jugular vein. Sometimes you can insert it from your subclavian. The main role of this catheter, exactly, it has a balloon inside of it. But this catheter has the following. If you take a look at this catheter, it has so many like little bulbs. What are these for? Don't worry about it for now. So, and here you even have like little needle that has air in it. So why would you have an air needle there? To inflate the balloon at the end of it. Why you would like to inflate the balloon? We'll speak about it in a moment. So the idea goes like this, guys. Do you remember when we spoke about the GVB, the jugular venous pressure? So, the jugular vein pressure, which was exactly the same as the what? The right atrial pressure, yes? So, let me use this picture. So, it says something like this. You remember, we had the A wave, and we had the C wave, and we had the V wave. Does anybody of you remember what does the A wave represent? Yep, exactly. What about C wave? It represents which structure going in which structure? Yep, it's ventricular contraction, but the wave itself is created by the bulging of the tricuspid valve inside of the right atrium. Awesome. Okay, the V wave, you know it, it's infilling. Okay, anyway, so we bring the Swan-Ganz catheter and we put it inside of the heart, okay? You put it inside of the heart here and you start checking. In this case, you are checking here it's written in Russian, Bravoi Beretserdia, which means the right atrium. So you are checking the right atrium. After you check the right atrium, you pass it forward, okay? You pass it to where? You pass it to the right ventricle and you check the pressure of the right ventricle. Also in Russian here it's written right ventricle. So next it keeps moving forward and it goes where? It goes to your pulmonary trunk until it reaches where? The pulmonary arteries. When it reaches to the pulmonary artery, it goes deeply, it can check the pressure inside of the pulmonary artery itself. After it being done with this, it goes deeper, the deepest point it can reach. The deepest point it can reach, it is the pulmonary capillaries, yes, which represents the left atrial pressure. Let me explain how that works. If I want to enlarge this, it looks something like this. So it is, let's imagine that this is the capillary, and now we insert this balloon, yeah? So we have the Swan's catheter going inside, and then we inflate the balloon inside, okay? So we inflate the balloon inside, and the pressure detector is located in red here, okay? So the balloon is inflated here, so the pressure cannot move forward, yes? So the sensor here cannot detect the pressure from behind, from the pulmonary artery. It means nothing for him. But what can this receptor detect? The pressure coming from after that portion. Well, which structure is located here after the pulmonary capillaries? What located after the pulmonary capillary? Left atrium. So exactly, the left atrium will be also pushing back, you know, because no blood coming forward, so he will push back. When he push back, you will be able to calculate the left atrial pressure correctly. Does it make sense, guys? Okay, again, so let's say that this is Swan-Ganz catheter. It's a catheter. We put it from the superior vena cava all the way through the right atrium, right ventricle, pulmonary artery, until it reaches the pulmonary capillaries. And like in each chamber it enters, we check. we check the pressure, okay? If the pressure is high, if the pressure is low, and we deal with it. So when it goes super deep, like the deepest point ever, it's here. When it's there, what do? We inflate a balloon. When this balloon is inflated, we basically block the walls. So the blood from behind it, it cannot pass. So the blood from the pulmonary artery cannot pass forward. If it cannot pass forward, it will not affect the what? The sensor. So the sensor will be only affected from pressure coming from the front. So the chamber that is located front to this pulmonary artery will be actually your left atrium. So this is the this area, the pressure at this area, we call it the pulmonary capillary wedge pressure, which is equal to the left atrial pressure. And it's a different way to detect left atrial pressure. Guys, tell me please, in case of aortic stenosis, what will happen to the BCWB? Exactly, it will be increased. What will happen to the BCWB in case of heart failure? Left heart failure. What will happen to the BCWB in case of COPD? No, guys, it will not be increased. It will be normal. The lung is here. Yes, the lung is here. That is not affecting the left atrium. Yes, because the lung is here, the left atrium is there. So actually they keep giving this question about ARDS. If you get a patient with an ARDS and they tell you that the pulmonary capillary wedge pressure was normal and you were thinking, is it ARDS or congestive heart failure? Which one you have to choose if the BCWB? ARDS is acute respiratory distress syndrome, which is due to hypercytokine release inside of your body. It's highly related with COVID actually. So in case of CHF, the BCWB will be quite high. And in case of ARDS, the BCWB will be actually normal. In sepsis, you also can have ARDS. In pancreatitis, you can have ARDS. In case of COVID, you can have ARDS. In case of lack of surfactant, you can have ARDS. So many causes. But that's for respiratory. Don't worry about it now. So anyway, if the concept of the BCWB does not make sense, now we'll read from first aid and hopefully it will make sense. So they write, pulmonary capillary wedge pressure is a good approximation of the left atrial pressure. In cases of mitral stenosis, the BCWB will be much more higher than the left ventricular end diastolic pressure, which is 10. So it will be higher than 10. The BCWB is measured with the pulmonary artery catheter called swan gas catheter that we have just seen. Okay? So now we'll speak about the autoregulations. So autoregulations include the following. So how does an organ controls how much blood you put inside of it? How does your heart know that, well, now I want more blood to come inside of my coronary artery, or I want less blood to come inside of my coronary artery? How can he decide that? The way he decides that by secreting local metabolites that can control this, okay? So let me tell you a little bit about these different local metabolites and how each of them work. Okay, so they write, autoregulation, it's how blood flow to an organ remains constant over a wide range of perfusion pressure. So in case of the heart, local metabolites, which are vasodilatory, of which vessel inside of the heart, someone right? Coronary arteries, exactly. So the coronary arteries will be quite dilated, and they will be dilated by the following stuff. The first one is adenosine. Guys, it actually makes sense, but you have not just to write it, you have to understand it. So guys, do you know what ADB stands for? ATB. If I have ATB, Adenosine triphosphate. If I remove one phosphate from it, it becomes ADP. If I remove one phosphate from it, it becomes AMP. If I remove one phosphate from it, what it becomes? Good. So when you have a lot of energy expenditure, you are using a lot of energy, you are using every single power molecule you have, like ATP, ADP and AMP, you are using all of them. You will have a lot of adenosine inside of your circulation, inside of your heart. And that adenosine is a local metabolite that leads to coronary dilatation, and that increases the amount of the blood flowing inside of your heart. I hope it makes sense. The next one is nitric oxide. Can someone tell me what does nitric oxide, which amino acid does nitric oxide come from? Arginine, excellent, L-Arginine. So, by the way, this is important actually. You know, a lot of people with sexual dysfunction, for example, like erectile dysfunction, they have a problem getting the erection itself. So one of the supplements you can advise them to take is not phosphodiesterase inhibitor, this is medication, but I'm speaking about a supplement. It's actually L-Arginine. Why? Because it increases your nitric oxide. In addition, it improves your motility of your GI. It also improves the making of nitric oxide, which improves the erection. So it can be used in case of erectile dysfunction. Also, when it leads to vasodilatation. So when there is vasodilatation, the heart will be, the coronary artery will be dilated. And it's mediated by cyclic GMP. The next thing you must know is CO2. It's just self-explanatory. If you have more CO2 inside of your coronary arteries, they will be starving for oxygen. So they will decide that they want more oxygen. How to get more oxygen? Vasodilate. The next one, it will be like actual decrease in the O2, like decrease in the what? Of your oxygen. So the heart starts starving. And when he starts starving, he starts secretes what? Sorry, he starts doing what? Vasodilatation. So, vasodilatation of the coronary artery. Okay, guys, I want you to know one thing. All of the vessels inside of your body, when they feel hypoxia, they dilate, except one, the lung. We'll speak about why in a moment. But for now, just trust me on this. Okay, inside of the brain, vasodilatory local metabolite will be the CO2. Remember, why it's not the O2? O2 does not have receptors inside of the brain, so it's irrelevant. It's only CO2. The kidney, it's something called the myogenic and the tubuloglomerular feedback. Guys, when I looked at this the first time, I could not understand it really. And I tried to read the explanation in many places. I could not until I saw this. So this is the only way I could understand it. So I will send you the picture and then I will explain it. No. So what happens that in case of the kidneys, there is the myogenic and the tubuloglomerular feedback, and it goes something like this. When there is more blood flow to your kidney, what happens that you will get more glomerular filtration. We spoke about it. So you have more glomerular filtration, you have more NaCl delivered to your macula densa. Your macula densa will sense that there is a lot of NaCl, so it will decide to secrete a lot of ATP, especially the sodium. You are correct, it's the sodium that it senses. So the ATP will be converted to adenosine. Adenosine, my friend, what are you doing here? Well, I'm getting modulated by this process here, getting modulated by the angiotensin 2, nitric oxide, bradykinin, and thromboxane. All of these substances, well, if you speak about nitric oxide, vasodilatory. What about angiotensin, guys? Vasoconstriction. Bradykinin, vasodilatory. Thromboxane, vasoconstriction. So they have variable function. So what's up with these guys? Well, it depends if it's high or low. If adenosine is high, he will utilize the nitric oxide and the bradykinin. If it will be low, they will utilize the angiotensin 2 and the thromboxane to lead to vasoconstriction. Anyway, in short, there will be increase in adenosine, which lead to high calcium inside of the mesangial cells, which are located, basically the mesangial cells are the cells inside of the kidney, like between the other cells, okay? They make you the parenchyma of your kidney. So there will be an increase of the intracellular calcium. And if there is a lot of calcium inside of a smooth muscle, what happens? Good. Vascular smooth muscles constriction, yeah? And that leads to vasoconstriction. Okay, if vasoconstriction happens, what happens? Decrease the blood flow. Okay, now let's imagine the other process around. There will be less afferent arterial blood flow, less GFR, less NaCl going here, less ATP, less adenosine, yeah? Less, and that will lead to what? Less intracellular calcium, vasodilatation, more blood flow. You saw how that went? That we call the myogenic and the tubuloglomerular feedback. Okay, now the lung. The lung is unique, in which hypoxia causes vasoconstriction. Why? Well, actually it's important to know. Because look here, guys, if we say that this lung has 3 alveoles, okay? Let's just, for the sake of simplicity, imagine that the lung only has 3 alveoles. And alveole 1, 2, and 3. If we say alveole 1 is doing what? Alveole 1 is getting the like this is 1, 2, 3, and let's imagine only alveole 3 has pus in it. Yeah, it has a lot of pus in it, so it's dysfunctional, it's not working. For the lung, is it beneficial? Is it alveole number 3 beneficial, or it's completely useless? Useless. So it sounds better to vasoconstrict the vessel going to it and to shunt the blood going to it to another alveole that is functional. Yeah? Makes sense, I hope. Like, since he's functionless, no need to waste the blood on it. Exactly. So you will send it to alveole 1 and 2 instead. So we go back here and they write, the pulmonary vasculature is unique in that the alveolar hypoxia causes vasoconstriction so that only well-ventilated areas are perfused. In other organs, hypoxia causes vasodilatation. So we just explained that. So the next thing we need to speak about is the skeletal muscle. So skeletal muscle have local metabolites. Do not get it tricked and choose lactate for the heart. Lactate is not the one for the heart. So local metabolite during exercise that are vasodilatory because you need more blood to go to your muscles are the chalk. So that's carbon dioxide, hydrogen, adenosine, lactate, potassium as well. Okay, so at rest we have sympathetic tone in the arteries. Okay, so the sympathetic tones in the arteries maintains the perfusion of the vessels. The last thing is the skin. Sympathetic vasoconstriction is the most important mechanism for temperature control. Think about it. If you don't want the temperature to escape from your body, you will do vasoconstriction to prevent the release of all of that temperature outside. And you will try to keep it in your core of your body. So like when the temperature gets cold, you notice that your hand gets cold. Why? Because your body is smart. He is protecting the more important organs, like your visceral organs. So your hand do not matter a lot, but your heart and your liver matters much more. So, okay. Next topic is really important. I will not explain it for you when you guys are tired right now after 2.5 hour lecture. So we'll call it off for the day. I hope you enjoyed it. This is the done of physiology basically. And the next topic will be all about pathology. Pathology is an easy sale from now on. It's super easy compared to the physiology. That's it for today's session. And I will see you guys. Well, Next class, it depends on you. I will make a poll to choose between tomorrow and the day after tomorrow. Okay? Okay guys, you are welcome. See you tomorrow or the day after tomorrow. You decide.